Yeah. Okay. So I'm Mike, one of the PGY Echo Fellows here at St. Mike's. I did my training last year at UHM within the Advanced Heart Failure and Transplant program. So that's kind of my experience. I'd like to thank Dr. Alexova, who's a heart transplant and advanced heart failure doctor at UHM, as well as an echo trained physician for helping kind of vetting this presentation. And so we're going to talk a little bit about the principles of donor heart assessment in totality, and then we'll talk about echo assessment and the clinical implications for echo assessment. And so, like any great relationship, the success of heart transplant is really about matching the donor and the recipient risks to optimize graft function. And so every heart is evaluated comprehensively in terms of anatomic, physiological, and functional suitability for transplant. And echo really plays a central role in evaluation of this. And every recipient has their own kind of unique set of vulnerabilities, how sick the patient is currently, how long they can potentially wait for a transplant, their degree of sensitization, so how many antibodies they have. If they have a lot of antibodies, they can only accept a small amount of donor hearts, and also how comorbid the patient is as well. All of these factor into essentially how long they can wait, if they can wait, and what type of heart they can essentially receive. And so when we think about the ideal donor in a perfect world, it's someone who is hemodynamically stable despite their illness that has ended their life, that they have normal echo function, that they're young, they have a low likelihood or no clinically significant CAD, minimally comorbid, so no hypertension, type 2 diabetes, dyslipidemia, chronic kidney disease, and that they have a short ischemic time. So what we say by that is they're like a local donor. They're here at St. Mike's if they're going to Toronto General, so they're not the donor heart isn't being received from a very far place away where they have to go on a flight, go to Pearson, be stuck in traffic for 2 to 3 hours is probably the longest time. It's just getting to downtown Toronto before transplantation. And so why are we taking higher risk donors, or why do we look at donor hearts comprehensively? It's similar to what Jackie mentioned, is that the wait list is just getting longer and longer, and the essentially need for heart transplantation has grown over the last decade. And part of that is access to medical care, but another part of that is that chronic heart failure patients are living longer and having access to these therapies because of new medications, new devices, new types of percutaneous interventions like mitral clip, tricuspid clip, that's actually prolonging these patients' life, and they become more complex in the end and potentially may be suitable for transplant, essentially. And so the purpose of this extended donor criteria is to expand use of hearts while mitigating recipient risk. And so basically what that looks like is it's all about having a balance. So you look at donor factors that would increase the risk of the donor, and you look at recipient factors that increase the risk of the recipient, and you try to balance that out. And so what I mean by that is a relatively older local donor with mild LVH, so those are just some mild risk factors, would probably be appropriate for a stable ambulatory patient that's waiting for a heart transplant at home. But you don't want to take that same patient that has type 2 diabetes as well as some mild CAD for someone who's in the ICU on mechanical support, because taking that donor that has some risk factors for graft dysfunction and putting it in an already very sick patient is not really matching those risks. Now, what I will say about that, though, is some of the unpredictability is how sick the patient is. So, for example, if the patient is on a form of a machine and they can't wait for a heart and that machine is failing, then sometimes we extend our criteria based on that, because this may be the patient's only option, essentially. And so we look at a variety of things. And again, most important is typically avoiding older age, avoiding sex mismatch, as well as avoiding ischemic time. And then comprehensive assessment of the heart also comes into play. And so the potential for TE as a screening tool was initially looked at back in 1988. This is the first article of the Journal of Thoracic Cardiovascular Surgery that looked at essentially echo as a potential screening tool for donors. And prior to this, donors were excluded if they were on a lot of hemodynamic support, if the donor was older or they had comorbidities. They didn't even look at the heart. They said, this isn't going to work for us. And so they also made decisions just on direct inspection. So how the heart looks. Is it scarred? Does it have structural abnormalities? Things like that. And so initially they had looked at this study to include hearts that may be transplantable, but they also then kind of, funnily enough, put in this article that, hey, this is actually good for excluding people because they found out that they transplanted someone with Epstein's abnormality. And they didn't know this till after the fact. And so on direct inspection, they couldn't see the anatomical, characteristics of Epstein's abnormality. They couldn't really assess valve function because you're just looking at the heart. And then when they transplanted the heart, they did an echo and they're like, oh God, this person has Epstein's and tricuspid regurgitation, which obviously isn't ideal. So the surgeons begrudgingly said, hey, this could be useful for other reasons as well. And so since that point in time, both TTE and TE have been validated for the use of organ donation by studies which demonstrated the feasibility to identify relevant anatomical and functional abnormalities. And so more recent data over the last couple of years has come out to say, okay, what echocardiographic abnormalities are relevant and what can affect essentially graft dysfunction. And so when we talk about echocardiographic assessment of the donor heart, it's a comprehensive study where we look at everything, but in particular, important to look at chamber size, degree and characterization of LV dysfunction, regional wall motion abnormalities, presence of LVH. Are there any septal defects? Is there any valve issues? And is there a presence of congenital heart disease or cardiomyopathy? And this is very important because some of these patients that come through with catastrophic brain injuries may have had a syncopal episode and they could be young and they may have something like hypertrophic cardiomyopathy or they have a congenital abnormality. And so identifying those patients are obviously very important. Chamber size can also be important because it's reasonable for some patients to have some mild LV dilation just based on hemodynamic characteristics of the donor. But if they have super dilated, thinned out myocardium, that again points to a potential underlying cardiomyopathy. Septal defects such as PFO can usually be repaired at the time of the surgery, but more comprehensive defects typically are excluded because those patients also may have some hemodynamic alterations where their right ventricle may be involved and would not be able to go through transplant. Specifically, the data has looked at donors with LV systolic dysfunction as well as donors with LVH and how those impact clinical implications. So we'll kind of touch on those two topics more comprehensively in the next couple of slides. As many of our sonographers know, donor assessment hearts by echo can be challenging. These patients are typically critically ill in the ICU. They have multiple lines. They're intubated. They may have bandages from motor vehicle accidents. They may have broken ribs, pneumothoraces. And so getting high quality pictures can actually be very difficult. And so use of contrast or even agitated saline just to look at the right sided structures or right sided size and function can be helpful. TE can be done as well, but there are limitations because you want to be able to look at the chamber size, wall thickness, as well as all of the wall segments, including the apex, which can be difficult with TE. And TE can also overcall some valvular lesions. In general, kind of mild to moderate regurgitant lesions at the AV valves can be tolerated because those are usually exacerbated by hemodynamic factors, which can be corrected, but any other type of stenosis or severe like intrinsic leaflet pathology causing more than moderate regurgitation it typically is excluded, essentially. And so in terms of LV dysfunction, there was initial data, again, back in the 1990s that LV dysfunction incurred a increased mortality in recipients. And so left ventricular dysfunction is the most common reason why you look at a heart on echo and you say this can't be used for transplantation. However, in the last, I would say 20 years or so, there's been mostly observational studies to evaluate this and see if they can be used. And so there was an initial article by Rheaume et al. In 2002, which looked at just over 200 hearts. They noted that 25% of patients were excluded just based on LV dysfunction. When they looked at these hearts, most of those patients were young as well as low BMI. And we know that in patients with catastrophic brain injury that are young, this LV dysfunction is not going to be secondary to coronary artery disease, but more so implicated in this brain-heart relationship where we see stress-mediated cardiomyopathies. And these types of cardiomyopathies are actually fairly frequent in those with brain death and can happen in about 20 to 40% of patients. And it is typically due to sympathetic catecholamine release, but also a lot of preload and afterload changes on the heart. So the patients are acidotic. They may be relatively adrenal deficient. They can have abnormal circulating hormones such as thyroid hormone, sick euthyroid syndrome, or a variety of electrolyte abnormalities. And over the last number of years, we've known that correcting these metabolic abnormalities and giving the time for the donor to recover has resulted in essentially recovery of these donor hearts. And so in the late to mid 1990s, a group out of the US as well as the UK essentially showed that LV dysfunction in most of the young donors can actually be resuscitated in about 90% of cases. And that resulted in a 30% increase in the ability to use these donors. And so this led to a number of protocols where we now resuscitate the hearts aggressively, both hormonally, electrically, hemodynamically, as well as with time to try to increase donor yield. And so this is a protocol that Dr. Ross and Dr. Rheaume at UHM were involved in Canada that essentially shows kind of hormonal and then also kind of hemodynamic resuscitation. And we know, again, that patients that may have this classical atypical Takotsubo, that we can see even more clearly this contrast here. Sorry. Where their apex is hypercontractile. If we resuscitate these patients and give them time, they can have normal restoration of biventricular function. And so a more recent or modern study in 2017 was the largest kind of registry study that looked at patients that had initial LV dysfunction and then recovered. And then they looked at essentially the clinical outcomes of those transplanted hearts. And so hearts were essentially distinguished between LVEF of less than 40% or greater than 40%. And they gave time to recovery up until the transplant where EF was essentially recovered. And they looked at over 10,000 donors, actually. So it's a pretty large number. And then what they found was that both the short and long-term mortality was essentially not different between the two groups. You can see that the final EF on the right-hand side, in the improved donor EF, pretty much all of them returned to normal. The range was 55 to 60, but the EF in the initial period ranged from kind of 25% to 50. And they looked at a bunch of secondary outcomes like length of stay in hospital, primary graft dysfunction, degree of infection, rejection, dialysis, and they didn't really notice much difference. Importantly, the median time between initial TTE, where there was significant LV dysfunction, and then normalization was only 18 hours. So in, I guess, contrast to our typical like Takotsubo patients where it can take weeks, this tends to have a much more rapid recovery, which is relevant for Trillium's planning, but also our planning because it often makes sense to do echoes even 10 to 12 hours apart, which may be the same day, to look for recovery, because a lot of the decisions made around organ transplant, as you can imagine, are quite time sensitive. And so this was then a follow-up study done in 2023, which looked at just over 4,000 donors. And this actually looked at patients that had initial LV dysfunction that recovered, but also a small percentage of patients that had initial LV dysfunction that didn't recover. So they actually were transplanted when their LV was in the 35 to 40%, so they didn't have full recovery. And so they had multiple serial assessments of TEs, and they found that patients that were more likely to recover had lower initial troponin, normal initial BNP, lactate, and fewer inotropic support, which makes sense. They weren't as sick. They didn't have as much of a catastrophic kind of myocardial injury. And again, they found that statistically there was no significant difference, but I will outline that you can see that there is a mortality drop right here in the patients that were non-reversible. This accounted for like 1 to 2 deaths. There was a very low number in the non-reversible, only 23 patients. So although statistically over the long term it wasn't clinically significant, there was a signal towards harm. It's just underpowered because of low sample size. So in Canada, we typically don't take hearts that show persistent LV dysfunction up until transplant, but this gave some preliminary data as early as 2023 that these potentially. And so overall, it's more likely that the more severe LV dysfunction and impact on regional wall motion abnormalities are relevant with other clinical factors. So if the patient is older, if they have comorbidities and LV dysfunction and they're not recovering, that it gives us more of a clinical sense that this patient is probably not suitable for transplant. But for a young patient with minimal comorbidities where we see initial LV dysfunction, we should aggressively pursue these hearts after resuscitation and constant serial monitoring to determine if they would be a candidate. I did look at, again, other risk stratifiers. And so there is some data that absolute level of troponin can help predict those that recover. And again, I think that makes sense. If there's a massive troponin elevation, that's more indicative of myocardial necrosis as opposed to more supply-demand mismatch and true kind of persistent LV dysfunction. We talked about serial reassessment with ongoing donor resuscitation. There's now a plethora of data that says that that is definitely the right thing to do to increase donor yield. And I did look at a study, because this is an echo rounds, about using debilitating stress echo. Not that I don't think we're going to bring them down to the bike or the treadmill, but there is some data for stress echo. But when I looked at this study, it was actually using dobutamine along with every other hormonal resuscitation. These patients got cortisol, they got thiamine, they got levothyroxine, they got steroids, and then they like sprinkled in a bit of DOD for a stress echo. So I would say that I wasn't just clearly looking at just stress echo in isolation, but they did kind of make a distinction that, you know, in assessment of donor hearts where they may not have accessibility to a cath lab and they can't invasively evaluate the coronaries, that stress echo may be helpful to look at recovery and kind of rule out likelihood of flow-limiting coronary artery disease to potentially enhance donor pool. But that's usually not the norm, but it is incorporated in the guidelines. When we talk about LVH, so this has been an interesting kind of field over the last number of years. Again, typically when we assessed a donor heart and we saw a degree of wall thickness or LVH, initial clinical studies showed that these recipients would not do well if they were transplanted with LVH. And then in the last decade or so, when they've done retrospective review of these patients, they actually found that, well, it's not necessarily just the presence of LVH or not, it's the degree of LVH and also other clinical factors. And so when they were characterizing LVH, they looked at the intraventricular wall thickness as well as the posterior wall thickness. And whichever number was larger, they kind of put into these categories of no LVH, mild or moderate to severe. And then when you look at the degree or the prevalence of LVH, it's actually pretty high. It's in about 44% of potential donors. And what they found was that just in isolation, LVH was not necessarily predictive of recipient outcomes. But then when you combine it, if there's moderate to severe LVH with both increasing donor age as well as ischemic time, that those recipients do much worse. in particular the moderate to severe LVH, again, in combination with other clinical factors. And so this is kind of an evolving field. I can only really find abstracts on this concept, but the thought is that, obviously not all LVH is created similar. LVH may be indicative of true kind of left ventricular hypertrophy from other comorbidities, longstanding hypertension, hypertrophic cardiomyopathy. Patients that are older age, they have diabetes, they have hypertension, they have dyslipidemia. Those patients are likely to do worse. But there's other patients that just have LVH because of myocardial edema. So those are typically younger patients that have myocardial edema, and that's why they have LVH on echo. And a way that we can actually distinguish between these is just going back to first principles and looking at ECG and seeing if there's electrical abnormalities that more fit with LVH, such as on the left, versus edema, where they typically have kind of low voltages, sometimes on the right. And there was a more recent abstract out of Dr. Kittleson, who's an advanced heart failure doctor at Cedars-Sinai, that looked at about 50% of patients, and those that had all of those favorable characteristics with LVH and were transplanted, about 70% of the LVH actually regresses post-transplant. So it was all likely more so myocardial edema as opposed to true intrinsic hypertrophy. Now, I'll quickly touch on valvular heart disease, and this is, I asked ChatGPT to make me a crazy surgeon. They gave them 6 arms because in general, anything more than mild to moderate regurgitant lesion is excluded, but there is some very limited data out of France and Italy where they actually took donor hearts that had moderate to severe MR, both primary and functional, and moderate to severe AS, and before the transplant they did aortic valve repair or mitral valve repair or replacement, and then put in the heart. And they didn't really give a lot of outcome data. They said all have returned to active unrestricted lifestyle at 6 years. So I have no idea what they look like, but they apparently all survived. But they did mention that all of these recipients basically were highly sensitized. They were on VA ECMO or mechanical support. They didn't really have any other option. And so that's why they kind of took these hearts almost in an experimental fashion. But again, it is built into the guidelines that if you have a highly sensitized patient that's critically ill and they don't have any other option, or they have a very limited donor pool, that you can consider trying to repair. But again, I don't think we've done that at UHN in the past. I know that there is less concern about some of these regurgitant lesions because most of them resolve after you correct the hemodynamic alterations. But also with the advent of the percutaneous options like TAVIs, mitral clips, tricuspid clips, those options are now reasonable down the line for heart transplant recipients. Whereas in the past, if you had to do another open sternotomy as well as heart surgery, that just wasn't an option for these patients because they've had so many sternotomies before. Okay, and in conclusion, so echo is really central to the diagnosis of donor heart assessment. Extended donor criteria has increased the complexity of donor heart assessment. And so principles to kind of take out of the study is that in young, otherwise healthy donors, LV dysfunction is not necessarily a no or prohibitive for transplant, and serial reassessment on very short intervals, 12 to 24 hours, is extremely important to try to increase donor pool, and that donors with with just mild LVH should not be prohibitive as well. And I think the overarching theme is that it's all about matching risk of the donor and the recipient, and so echo findings have to be integrated with all of these other clinical parameters to try to optimize outcomes. References.